simulation use in the practice of perfusion and get into some of those details. The next one is to gather input on the future use of simulation in our perfusion practice and really look at those best applications and how we're using those. Third is to review the options available today for you to include simulation in your perfusion practice. And then finally is to generate some discussion and dialogue, which I hope will occur not only during my talk but afterwards. So how did I approach accomplishing these objectives? Well, I wrote a number of questions that I thought we needed to try to answer. The first one, is there a shift in caseloads or case coverage that could affect how simulation is used? Next, how is simulation routinely used today in clinical practices? Then I wanted to know, what experience do practicing perfusionists have with simulation? Is it valuable, and what are those limitations? And then finally, what are the future applications of simulation? Where are the gaps and where are the improvements? And hopefully from answering these questions then, we as a community of people providing care for patients can use the best possible tools to deliver that care. So to get this project started, I first did some background work. And that included interview with perfusion simulation developers, specifically Paul Curtis with Eigenflow, and then Richard Talman, who I think many of us know from Biomed Simulation. Then I spoke with thought leaders at the various perfusion leadership organizations, AMSECT and the Academy, and got their thoughts on what was going on. Then I expanded that conversation to the leaders at perfusion schools and got a sense of where simulation fit into perfusion education. From there, and from their input, I developed a survey which was launched last December, and we took the results of that, and then that becomes the essence of this presentation. Now, a follow-up step yet to be done is to review these results with those initial groups and then find out what we think next action steps ought to be. So this project is not concluded at this point. The survey, as I said, was launched last December. I was able to get 85 responses, which I thought was really good. 2 of them came in after the closure for the preparation for this presentation, so they weren't included, but we did get 83 of them involved. The demographics from the people participating I thought was very interesting. So 57% from public and private hospitals and 33% from academic hospitals. 58% are direct employees, 32% work for contract perfusion groups. And you can see the smaller numbers. So in many ways, I think this is a good representation of the cross-section of practicing perfusionists today. So you might see where you fit into these groups. Now, in terms of the number of cases that are done at each of these centers, I also found this to be interesting. So the large bar in the middle, if you can't see the numbers in the back, are 500 to 1,000 cases. That's a pretty good number. Smaller number of centers that do more than 1,000, and that's not a surprise. We probably all know where those centers are. A good number, 25%, are in the 250 to 500 range, and then I was surprised to see how many are in the 250 and below range, which that might be an interesting place for simulation to help keep up competency if you're not doing cases or multiple cases on a daily basis. In terms of experience from the participants, this was also interesting. The large bar at the bottom, 89% have more than 10 years of perfusion experience. If you look at the American Academy Registry of Perfusionists, the group is getting fairly senior in terms of experience. There are not as many new perfusionists coming in as there are practicing, and that's reflected in this response. So I found that to be interesting as well. In terms of caseloads and those changes, the question here was, compared to 2015, the number of bypass cases in 2016 that includes wet standby with a perfusionist immediately available is, and that answer, the bar in the middle is about the same. The one below that is increasing but less than 10%, and then the one below that is increasing by 10% or more. So what's interesting there is that perfusion is very viable and it's growing. So we can feel good about the profession we're involved in. But that increasing by 10% or more indicates to me there may be some shift in the centers that are doing cases from the smaller ones to the larger ones. And we'll have to see how that shift plays out. The next question was the number of wet circuit perfusion standby cases that do not go on bypass, and asked that by percentage. And that big bar in the middle there is 50% for about the same. So that's not changing. But what's really interesting is the increasing is at 25%. So that means we're seeing more cases that you've done a wet pump standby, but you're not getting perfusion experience, just did the setup. So those standby and no bypass cases are a significant part of the caseload that we serve. There's a lot of information on this slide, so we'll try to go through it kind of slowly. The question was regarding the use of perfusion simulation as a part of our orientation and training, and I wanted to understand how it was being used. So for perfusion students or for new staff, 47% do not use simulation at all. Only 13% used high simulation, and 32% used low. So my definitions of low and high for the purpose of this survey, low would be anything that didn't involve an electronic device. So it could be tubing in a bucket with some clamps. You could have a pump. We would not consider that. But there's no automated system that creates the simulation for you. And then opposite of that would be the high sim, the one that has auto-regulation and computer programs that give you the challenge and the scenarios. The next question was, as a part of continuing education for experienced staff, 58%, no use of simulation. Only 9% using high, and 27% low. So of those using simulation, we still do a lot of lo-fi sim, which is very valuable. You've probably got expired circuits and a way to practice that. As a part of continuing education for non-perfusion ECMO staff, which is interesting because the Eigenflow system is designed simply for ECMO training, 17% high, 19% low, but 53% none. So how are non-perfusion ECMO staff being trained to help maintain those circuits if they're not using simulation? That must mean they're doing it all OJT with live cases. And that may not be the best scenario. So there may be an opportunity for simulation here. Another look at the current use of simulation, I went back and looked at a paper that Rich Ginthner published in 2003. And he looked at department use of perfusion crisis management drills for 2002, and he did a survey. And he had 59 respondents, and 97% of those respondents agreed that regular practice was important, but only 17% of practices at that time required it. There was a big gap in the need for this, but yet it's not mandated. The reasons that it wasn't mandated were very interesting. A majority of people thought it was individual responsibility, 40% of those. 22% were not motivated. That's a little concerning, particularly in a crisis situation that you might not be faced with on a regular basis. 19% were confident in their proficiency. That's interesting. I won't discount that, but if you don't practice it and you don't have routine emergencies, how are you confident? 17% no time. I think we can all relate to time being a pressure. And then smaller values on dubious value and cost prohibitive. So I decided to re-ask that question that Rich Ginthner had asked. And in 2016, from this survey, now 45% of institutions mandate practicing those skills. Of those not mandated, Rich found that 39% said practice as an individual and it's your own responsibility. Now 59% think that they need to practice on their own, which that's a little disturbing too. I'm not sure how we get to that. If we go back and look at this earlier slide, we'd seen that 58% of practicing perfusionists don't use simulation to practice. So we've got a little bit of a gap developing here in how do we maintain skills and proficiency. If we look at the rest of the reasons for those that were not mandated, not performed due to a lack of access to pumps or supplies, that's interesting. It now has gone up from 2% to 10%. So does that mean there's not the spare supplies around that you could practice a situation in a corner? Maybe that's something we need to figure out how to solve. In the not needed caseload experience maintains adequate skills. That's down slightly, but it's about the same, which that's interesting. Not motivated or lack time or energy to practice. Very encouraging that that's only down to 8%. So I think we're taking bigger responsibility that these skills are things we need to keep sharp. And then in the not considered valuable, normal casework is adequate. It's up slightly, but I wouldn't say the change from 2 to 7% is significant. So some interesting trends coming out of the information here. So I want to switch to talk about the current use of simulation. How's it being applied today? So I asked the question, at my institution, what are the reasons simulation is not used or not used more frequently? The largest response, we got down there at the bottom, is lack of access to a high-fidelity simulation system due to cost. And that came in at 51%. The next groups were that it is not supported in the clinical program, or there's a lack of an education program that's formal that I can open up and jump into and use. So again, I think there's some gaps and some opportunities for us to fill. In terms of personal experience with simulation, the question was, I've personally used perfusion simulation for the following purposes. The highest rank was rehearsing emergency procedures. That's probably not a surprise. Hopefully most of you practice an emergency procedure like an oxygenator changeout in a simulated situation on a somewhat regular basis, or you've at least tried it and gone through your protocols. Introduction of perfusion students or non-perfusionists came in at 55%. And that's a very valid application. Rather than watch one or come in and see an OR, have a seat at a pump and let's have you put the clamps in your hands and turn the knobs. And simulation can allow that. And then training on new devices or procedures. So if you're changing from one vendor to another, simulation is a great way to work out those bugs. The next question I asked was, based on my opinion and experience, rate the effectiveness of perfusion simulation for a number of different applications. The highest ranking, again, no surprise, was rehearsing emergency procedures, such as a changeout. Training a non-perfusionist for ECMO support was also highly regarded. And then interesting, recreating emergency situations to review and improve responses. So as we become a more litigious society, I think we've probably all been involved in one degree or another of an investigation around a clinical incident. Simulation can be used as an investigative tool, and it can also be used to test a new procedure or a protocol so that you know where the bugs are before you apply it to a patient. I want to shift to the future use of simulation, which I think will be interesting as well. The question was, what plans do you have for the future use of simulation in your practice? Interestingly, about 35% had no plans to change at all. Another 35% will continue what they're doing today. So there's not a whole lot of activity in the mainstream of perfusion practice around simulation. But I can tell you from my other experience in this project, that's not the case in education. It's very active and viable there. And I wouldn't be surprised to see education take the lead in how this gets applied in regular practice. Next question was, if an accredited program were developed for perfusion at a full-scale dedicated simulation center for a reasonable fee, would I be willing to attend or send my staff? And a large majority, 55%, responded yes. And in fact, I got a lot of comments back on the survey. Are you going to start a program like this? Is there one I can go to? Is there one coming to a town near me? So this is an area that I think has a great deal of potential, and I think we'll be seeing more in that area. The use of simulation for being appropriate for meeting partial case requirements, we are still very divided on. Now, as we look at more wet pump standbys, our interest in this may increase if we're not getting enough cases to meet our annual requirements. Then you have to ask yourself, how rigorous is the simulation that I'm going through that I'm getting credit for towards a case? Or should it be like a 2-to-1 ratio? Or should that experience be done under a formalized education program? So we're still very divided in that. One thing we're not divided in is the use of simulation for perfusion examinations. So 73% thought this should be a part of perfusion certification, which certainly I think everybody agrees makes some sense. I've had a chance to visit a number of different simulation centers, both for perfusion and medical practice. This is one at a perfusion school at MUSC that Joe Sestino and Dave Fitzgerald run. Very, very good program. They've gone to a great deal of lengths to make things very realistic for their students, how they set up OR lighting, communication skills. They even have a simulated heart and a patient at the table. So they've done a very good job there. Another one is at SUNY. These pictures were sent in by Bruce Searles, who also helped me prepare the survey. Very active program. They use a blood analog here, or sometimes bovine blood, and the perfusion students get a very realistic experience. This is another picture of the mannequin that they have up at SUNY. This is a program that is at Harvard Medical School, and these full-scale medical teaching labs, if you haven't had a chance to be in one yet, I would strongly encourage it. These take on every aspect of the clinical experience you could imagine, and they do it in a controlled way, and they even create the right psychology around that clinical environment. Then they carefully, without you knowing it, introduce challenges and stresses you don't see coming, but they do, and then they can grade your response on them in a very positive way so that you can now anticipate how you'll react to different situations. This is a fascinating area of medical education. Another one of those is at the Hannaford Center at Maine Medical. I had a chance to tour this center, 6 fully functional simulation ORs. They also have pre-exam rooms, and they hire actors to come in and play the patients. So the actors are briefed on here's what you should do and say and how you should act, and they put makeup on them so that the student who's going through the program gets a very realistic experience. It's truly fascinating. Give them a lot of credit. There's 3 other ways that you can get simulation to benefit your practice. The high fidelity we've already talked about with the Califia, the Eigenflow. There are other systems that are out there. Low fidelity, I don't think, is being overlooked. We just don't talk about it much. But if you've got expired circuits that you can't use on a patient, don't toss those out. Set them aside and have a sim day. Practice things that maybe didn't go well on a case that you were losing a little sleep over. How could I have done that better? Practice an emergency of a filter plugging or an oxygenator issue or something like that. Virtual experience is also possible. There are a number of different systems available that you can just pull up on a computer to simulate a case. This is one from the University of Hawaii. It's called ECMO Joe, where you can do a virtual ECMO case right from the comfort of your desktop, which should be really interesting. And there's some other systems that are out there as well. There is now a simulation task force that is a part of AMSECT. They are developing standard education guidelines around simulation and how it should be used. I would encourage you to get involved if you're interested. I'm sure they would welcome the help. It is a core group within AMSECT, but always welcome to new membership, and they'd be very interested in hearing from you. I borrowed some slides from a presentation that Bob Dyga did, and Bob's sitting over here in the front row, which was a fascinating presentation. He took a look at the crystal ball of perfusion and spent a long time working on this talk and then presented it last year at the CREF meeting. And then I took that information and tried to see what could I learn from that and how it might affect the future of perfusion simulation. ECMO was one of the first things that came up. ECMO is rapidly growing. As you can see from the graph on the left, the number of cases per million adult discharges is increasing, but yet cost per day and cost per patient is staying flat. What does that mean? We're getting more efficient at it. We're getting better at it, but yet caseloads are increasing. If we look at ECLS, one of the conclusions that Bob came to was that ECLS can be managed by ICU nursing staff instead of ECMO specialists. Where are they going to get this training? How are they going to get good at this? Again, this is where I think simulation could have a wonderful application. Another one of the slides from Bob's presentation, ECPR is a viable treatment for select patients. However, in an emergency situation, there is less room for error. That means you need more time for practice. And they're going to have to practice those scenarios to where they have them down and they can all respond as a team in an emergency situation. ECPR is not a routine situation, so our normal perfusion protocols are not going to apply. If you're called into one of those cases, you probably have to be a little bit more creative. Where will the basis for that creativity come from? It'll come from all of your experience, including clinical, but perhaps also simulation. ECPR also often involves non-CVOR personnel. They will not be familiar with your technology, your equipment, or your language. So again, exposing them in a simulation environment could bring some real benefit. So I want to wrap this up with just a couple of comments on the future of simulation. Again, I come back to the aviation because I think there's a lot of parallels there. I believe that perfusion simulation will continue to be a part of what we do. Perfusion as a practice is viable, and it's a growing therapy that I think there's going to be continued application and need for. Simulation will increase in realism as we go forward and benefit to the practice of perfusion. It will certainly continue in education, and we're going to see it increase in normal practicing perfusion practices. I think it'll also have an increasing role in competency assessment. So it will continue to be a part of exams, and I wouldn't be surprised if at some point it becomes part of an annual refresher requirement that you spend some time on a simulator. So with that, I will finish up and ask if there's any questions.